Hey, everybody. Happy Monday. I don't know, happy and Monday go together, but we'll throw it out there. So, hope everybody had a good weekend. I don't normally do Monday healthcare happening broadcasts, but I was attending the CPT Symposium last week, Wednesday, Thursday, Friday, so I couldn't do it last week. And I wanted to just kind of throw my thoughts out about the symposium and all the different stuff that is coming out. So we'll give a few minutes for people to start coming in. And as you come into the broadcast, if you could please just drop a little comment or something so that I know that I've got people coming in. Let me go over here and this down there. So give me a little wave or a thumbs up, or just type in the comments that you're in. I'll wait a few minutes and then I will just start kind of going through a little PowerPoint I put together on, kind of highlights over the changes that are going to come January now. And no, we're still in November, so in about a month and a half, a little less than a month and a half now. It is nice and sunny down here, so it's nice to be back in the sun. No, sorry for all y'all people out in the snow. I see Kimberly there. Hey, Kimberly, good morning to you. Hope you had a good weekend. All right, let me oh, Edwina, hi. Oh, you're quite welcome for the invite. I'm glad to have you. I'm glad to have a lot of people on. Wonderful. Everybody's coming in now. Alexis, good morning to you. Whitney, oh, hi, Whitney. I'm glad you could make it in. And someone else is saying morning to everybody. So I know those people that are on the West Coast there, we have quite a little bit of time differential here. So I think the 3 hours behind me. So it's like 8:30 there. So top of the morning to y'all on the West Coast. Um, oh, thanks, Kimberly. Again, a lot of comments in. Let me see what else is coming in. All right, so let me pull up the little PowerPoint I put together. Y'all are going to hear my dogs probably chiming into the background here. We have somebody coming in, plumber coming in and working, putting some new stuff in the bathrooms or something. So the dogs will be letting their presence known as usual. So you'll have to forgive that, please. All right, so let me pull my presentation back up. And now I will share it with y'all. All right. So as I said, I just put together a little bit of a recap here, just hitting, big main highlights of what we did, because obviously I can't fit in to 40 minutes, 45 minutes, everything that I saw in 2.5 days. So, but it was a very good symposium. I really do encourage people to, if they can, get a chance to attend the symposium to do that. It's a little, pricey depending on, what your practice is used to spending for conferences and things like that. But what is good about it is that you get to hear from the RUC committee members and the panel members on CPT that made the new codes, to talk about, why they made them. And then the CMDs from different MACs are there. This year they had 3. And so then after the codes are talked about, then there's like an open Q&A, and the CMDs, the contractor medical directors, then can weigh in on things that they'll be looking for when they are looking at the codes or asking for medical records or different things. and what their take is on different issues that come up or questions that come up from people that are attending the symposium. And they they did put out that next year for the 2023 symposium, as long as Chicago is open, they're planning on having the symposium be live again. It may be live with like an online option, so like a hybrid kind of thing. They really weren't sure yet. They surveyed everybody to kind of see, what our thoughts were on it. But if you get a chance, it is a good thing to go to, and it's good networking, of course, too. So, but onto, my little slideshow here to kind of show you what came up and what we were talking about during the CPT Symposium last week. So what I put here is these are all the specialties where they discussed different changes that are coming in to CPT for 2022. So E&M, path, radiology, digital medicine, which I thought was very interesting. So I'm going to talk about that for a few minutes when we get there. I've got slides, for each one of these to kind of talk about different things with them. Anesthesiology, pain management, vaccines, of course, with COVID-19, that was a section that got discussed and had a lot of additions to it. Some things really good in that section. Also, neurosurgery, orthopedic surgery, Odo had some interesting changes to it. Ophthalmology, same thing. Cardiology, cardiothoracic surgery, interventional cardiology, a big change for those are all that do caths, cardiac caths with the PD caths. So we'll stop there for a second. Urology, and then they had a presentation because they did it as a hybrid event, or sorry, as an all virtual event this year. It gave them some time to do like an extra kind of session about general type of things, and they chose social determinants of health. So they had a whole I think it was an hour, but they had 3 different speakers. Nellie Leon Chizun, and they had someone from the AMA, and they had someone from interoperability taking a look. And so they kind of really talked about social determinants of health from different perspectives, like how you bring it into your E&M visit, how to document it properly, what kind of effect it has on your selection of E&M service. And then Nellie talked about from an ICD-10 CM standpoint and where kind of the SDOH codes came from and the background and things. And then they had an interoperability person on there talking about what they can do with the data and the different gravity projects and things like that are out there. So it was kind of neat. So with E&M, what they talked about was editorial revisions to the E&M guidelines, but not, the ginormous thing we had this year. So they tried to shore up, some things where they thought that there may have been a little miscommunication or make something a little better somewhere. So not anything really to like freak out about there. But they do have some new codes in the E&M section for PCM, or principal care management. It's kind of different from chronic care management in that we're talking about one complex chronic condition that they don't expect to be used as an ongoing basis. So they expect to see it just, for a few months on a patient when a physician is taking care of something, like newer conditions or diseases that the patient may have when they're trying to set up like treatment plans and ongoing management and things like that. So it's kind of interesting in the principal care management that it's like a sister code to the chronic care management sets. But of course, they went through and in that section where they made it, then they had to make revisions to all the other codes about what you can and can't use together. So make sure as you're going through your CPT book in that section, especially for primary care and specialties that, do these types of chronic care issues. And notice again that it's got complex chronic condition. So, and the CMDs from the different MACs, really kind of push that when you see complex in there, that if we are requesting records, we expect to see some robust data for these codes as to what was going on, not just 5 minutes on a phone call or 20 minutes looking at something, or on multiple different days, a little bit of information, a little bit of meat in there. So make sure that your documentation is sufficient enough to support the services that you're billing. Also in a separate session, so they had E&M twice. They had it once for like this general overview of the whole section of E&M. And then they also had a section where Dr. Holloman and Dr. Lee, they kind of went through some of the common questions and to try to shore up a little bit more the issues with the office visit guidelines. So more questions about how do you count data review, and how do you count the independent review, and those kind of different things. So there was a separate session where they did kind of like a Q&A on those common questions that have still remained on the 2021 E&M office visit changes. So I expect that, we're still going to have some issues with the office visits for a little bit while people are still getting used to them. I don't know about y'all, but I'm still seeing some issues coming back and forth on that from different providers, just still having an issue with getting that stuff set up, and especially from the coding standpoint and auditing standpoint of counting things when it comes to that whole, did you order it, are you getting paid for it separately, all that kind of stuff. So they tried to do a little Q&A thing on that, but it wasn't where we could ask questions live. It was, they had taken them and made them into slides about common Q&As, but still very good. So in the Path and Lab section, they have they have a new COVID test, of course. So any section where you had anything that might have something to do with COVID, you had new codes. So they do have new tests for COVID. They also have under the vaccines, as I said, when we get to that section, there's some new vaccine codes in there too. They also had a lot of new PLA codes, which are proprietary laboratory and analysis codes or analyses codes. So they're in addition to the CPT code set that was approved by the editorial panel from the AMA. So they're alphanumeric CPT codes, but they have a corresponding descriptor that goes to labs or manufacturers that want to more specifically identify their tests. So these are specific tests to specific labs from specific manufacturers. So the tests with the PLA codes have to be performed on people, and they have to be requested by the clinical lab or the manufacturer that offers the test. So those are the people that request to CPT to have these new PLA codes made. So the section includes things that are tests to advanced diagnostic lab tests, clinical diagnostic lab tests, as defined under, the Protecting Access to Medicare Act. So you have a lot of different PLA codes, which I thought was an interesting thing, because to be honest with you, I'm not a lab heavy person, but I had not heard about these PLA codes. And so they have their own section, and you will find that in CPT. For instance, I'm just reading off of one of the codes here. They have a transplantation medicine measurement of donor and third-party induced CD154T cytotoxic memory cell utilizing whole peripheral blood algorithm reported as a rejection risk score. And that is from Pleximmune and Plexigen Inc. So it's things like that that are specific from a specific company asking for a specific thing. They also made an appendix for this in CPT, so that, these things all will have a separate place to live, and you can kind of look at that. So I would check that out in your new books. It's Appendix O. So take a look at that. In radiology, they have some new CT and ultrasound codes. They also have, and there was a lot of category 3 codes this year. So there were, and that's throughout CPT. But in radiology, we had ones that are going to be added now for percutaneous ultrasound guided G-tube placements, thyroid nodule ablations, and histotripsy when they're doing the destructions in the liver for tumors and things like that. So kind of neat in the category 3 range. A lot of these are things that are just emerging more and more, and so many things are emerging that we keep having a lot more category 3 codes every year. And there are a lot of the new codes that are category 1 codes now that were converted from category 3 codes. So that's really interesting. What it tells me is that, the things that they're putting in the category 3 codes are really things that are forefront technology kind of things, and that are really being used out there. Because if they were putting a lot of things out there that were just getting sunsetted in 3 years, it kind of puts it up to me that, that's just kind of like a feeler, and they're just throwing stuff in there. But a lot of the new CPT codes are coming from the category 3 codes. So that's, I think, a good thing to see. Then we have digital medicine. That is a new thing, and I think that's really well, it's not a new thing, but it what they've done to it is made an expansion into RTM, and we now have RPM. So we have that remote physiologic monitoring, the things for like the blood pressures and the different things from a physiologic standpoint for the patient. But now they've added a section for remote therapeutic monitoring. And I just noticed on my slide there, I have my acronym wrong. It's not RMT, it's RTM. So that's going to be a new section in digital medicine. So you have RTM versus RPM. So you want to make sure you're looking in the correct section. Currently, the RTM is specific to organ system. So they have 2 in there now, musculoskeletal and respiratory. But they said the physician that was giving the talk said that he expects, and the panel expected, that that's going to grow over time, and you're going to see more RTM codes for therapeutic monitoring, and they're time-based codes. So kind of an interesting section. So one of them, they're really kind of looking at asthma, COPD, that kind of thing, and checking on the therapeutic monitoring of different things that they're doing for the patient to try to correct those problems. So make sure you're taking a look at those sections. Also, they have codes for DBT being done online. So you have cognitive behavioral therapy, and then you have DBT is another form of therapy. And these are when patients now can do them online, and it's monitoring for doing that kind of behavioral therapy programs in an online fashion for patients. So I thought that was pretty neat. So that's something that you'll want to take a look at if your practice does those types of services for patients. And again, category 3 codes were added in there. From an anesthesiology pain management side, not too much in that section, but they had some anesthesia services for image guided procedures, which I thought was neat. They have them in new ones in for the spine and for the breast. So that's a section. Anesthesia, to be honest with you, is one that I kind of struggle with. Too many charts and too many minutes monitoring and things like that I just kind of get lost in there. I rely heavily on my friend Tanya Bevan when it comes to anything anesthesia, and Bridget Ortega, because it's just it's a little much for me. So it's interesting, but it gives me a headache. So Next, the vaccines and neurosurgery. And I didn't put these together in any specific kind of order. It's just, to save space, so I wasn't doing 8 million slides that had, two things on them. That kind of irritates me a little bit. So I try to make it compact for us to take a look at. From a vaccine standpoint, more COVID codes. They do have a new appendix for the vaccines, and I think it's going to be very helpful and very useful. But they did say that the codes are not complete in the CPT book because of the recent thing with all of the boosters coming out, and then now how they have made them for the doses for children and things like that. That stuff wasn't there when they made the CPT book and the codes, prior, because obviously they didn't just create the CPT book last month. So there are some things where the book is not complete, or there's already addendum or errata and things like that that come out by the time we physically get the book. And this was one of them. So when they made the book, then the booster and the kids shots and those things came out. So in the CPT book, it doesn't have the complete listing in the appendix, and that's Appendix Q. But online, the AMA says they have the complete listing. So you can go on to the AMA website and find the complete listing for the appendix. Also, in vaccines, they had some new ones for encephalitis, Ebola, pneumonia, the pneumococcal, and Hep B. So, but the biggest issue there, the biggest draw there, of course, is the COVID stuff. So make sure you check out that appendix, but make sure you go to the CPT, go to the CPT website, the AMA website, to take a look at that full appendix list. And then in neurosurgery, we had some intracranial laser interstitial thermal therapy. They call it LIT. Arthrodesis decompression. I thought that was pretty neat. And another nice thing that I found when you get your CPT book, that was one of the things that I found interesting. Yeah, but bad interesting, unfortunately, for a lot of people that attended symposium this year. The books they didn't get their CPT books prior to, going to the symposium. And of course, the supply chain thing that's going on everywhere affected delivery of CPT books. So there are a lot of people that didn't have their books when we were sitting through symposium. Luckily, I had mine. And in the section with the arthrodesis decompressions and things like, they have a lot of nice images in the CPT this year that are new, that give different imaging of the decompression. So they're looking at it from different angles, and from, removing the laminas and the pedicles, and when you do this and that, and what it's considered, and, decompression versus something else. And so for all you ortho people out there, make sure you take a look at that. I think you're going to like it. And then they talked about destruction of the basovertebral nerve, and had some category 3 changes to some new category 3 codes. In the orthopedic world, we had some revisions to the musculoskeletal guidelines, and that was kind of the big thing in that section, was that they're going through the 20,000s, and they redid the whole beginning section. So they separated different things out and made it a little bit cleaner, a little more explanatory in a straightforward manner. So you have a new section for fracture care. They have new definitions in there. They have a new casting and strapping guidelines, because for some reason they don't think that it was straightforward enough to people, that if you're doing fracture care and you place the first cast on, you're not supposed to bill for the first cast. For some reason, people continue to have issues with that. Or if you take off the cast that somebody else put on, the fact that, you're allowed to bill for that, still people are having trouble with that. So they just put different things like that have been like common knowledge if you work in that specialty area, but I guess not so common outside. So that I think is a good thing that they're more explanatory in there on those things. They tried to just be kind of, you bill for this here, you can't bill for it here. So that's something you want to take a look at. And then from the oto section, from the otorhinal, oral for otolaryngology and otorhinolaryngology, they fit both of them under that section. We had some new nasal bone fracture. They split out the nasal bone fracture code into two different codes, and they have it like a with and without stabilization, because there were some, again, questions about valuing of the code. Depending on what type of treatment you did for it, you could either be being not highly, but you could either be being overpaid or underpaid, depending on which way you treated it, kind of thing. So they thought there was enough variation there that they needed to study it and see if they needed to break it up. And the RUC committee agreed that they did. So now you have the nasal fracture that is split into two codes. So they deleted the old code that we had for it, and they made a couple new codes for it. Also, they have drug-induced sleep endoscopies, or DICE, and then transcutaneous passive implant temporal bone. The way they explained it is kind of like a BAHA, but it's an implant. But it's pretty neat. So they have a whole new section of codes in for that. So if your ENT docs do that kind of stuff, you'll want to take a look at it. They said it's kind of like the difference between having the screw versus having like a magnet. So with the new way, they're not going to have anything external, like poking out kind of thing, like where they have the screw coming out with the other devices. So kind of neat. I don't know if it's going to be more of a preference thing. They did say when they had the external screws that patients did have issues with infection and things like that. Now with this, because it's more, they're using the magnet instead, you don't have that issue. So something interesting that I think that, we're going to see more of in using it with these temporal bone implants. So take a look at that section if your docs are doing that. Then we've got ophthalmology cardiology as the next ones going down my list. With ophthalmology, they have some for dilatation of the aqueous outflow canal and cataract removal codes. And so retinal detachment. The one I found the most interesting, and just because I just thought it was neat, the when they insert the plugs in the cannulicula plugs, when they put the plugs in for patients that suffer from allergies, things like that, so they're trying to help them out. Now they have new ones that have drug insertion. So they have the cannuliculus drug insertion device codes. So that's something new in there. Under cardiology, they have some 3D cardiac structure imaging, cardiac ablations. They have a new ICE add-on code for intracardiac echo, where they've expanded what you're able to add that on to and use that with. So they're kind of trying to put it out as a more useful treatment when it's done, that not treatment, but diagnostic when it's done during other procedures, that we're able to expand when we can report it. So that's a really big plus for cardiology people. And then also some autonomic function test code. There was one, where they did the Bexy. They deleted that because they said nobody does it anymore. And actually the RUC came back and take a look, and it was a very low use code. So they just deleted that code. And then in cardiothoracic surgery, they have some new codes for exclusion of the left atrial appendage. Very, very interesting watching the CT surgeon that was talking about this. He did a good job. of doing some visuals, which is always, for me anyway, I like that kind of stuff. So he was showing some stuff, and you would see the beating heart when they were doing some of the procedures, and had the chest opened with the spreader. So it was a full on CT procedure that they were showing there. So I like that. For those of y'all that are my CT people that do cabbages, um, I love coding cabbages. I love watching cabbages. I hope I never have to have one, but a cabbage is a coronary artery bypass graft, and we currently have the codes for when they most of the time they did use the saphenous vein in the leg because, it's very long. You have a lot of it, so if you had some disease, because usually, of course, people that have to have bypass grafts have, coronary disease. And sometimes it goes through into where it's into the whole vascular system. So sometimes their arteries and veins are kind of gunked up too. And so what was nice about using the saphenous was there was a lot of it. So, if there was some pieces that were gunked up, you could find, some better pieces. But now they're using more into the internal mammary arteries and things like that. In fact, the CT surgeon that was speaking said the most commonly used conduit, which is a piece of, artery or vein they take to make the graft, they call it a conduit. He's the most used conduit is the Lima currently. So they have a new code they added for harvesting the upper extremity artery. They have one now for endoscopic, and they have one now that's for open. So they've added them just like they have the add-on code for the endoscopic one in the lower extremity. Now they've added them for the upper extremity because they're starting to use those more and more. And if you think about it, when you're doing a cabbage, when you're doing a bypass graft, you're, bypassing, going around something that's gunked up in the heart and the coronary arteries. So arteries are bigger than veins. So if you take a piece of vein and use it as the conduit to bypass and connect it to an artery, you're having the bigger artery, then the smaller piece of vein, then back to a bigger artery. And so they thought, well, maybe it's better to use another piece of artery. So we got a bigger artery, the same side artery onto another artery. So, and they've had a lot of success, once they've moved more into using arteries for conduits and things like that with the cabbages. So, it's nice to see that, we have additional codes now to be able to report the harvesting of those upper extremity arteries. And then there's a new code for a poem, which is let me look and make sure that I'm saying it right because I got it because I want to say perioral, but that is, of course, the mouth, and it's per, peroral. Give me just a second. I'm looking through my notes here to make sure that I'm getting it right. Now, isn't that that was CT surgery? Okay. Peroral endoscopic myotomy. So they call it a poem. So when they do that, they are usually doing it for patients that have achalasia. And so they've added a new code on, and it's 43497 for the poem, which is a lower esophageal myotomy done by transoral method, which is where they have the peroral, where they get the that part of the poem acronym out of it. So that procedure is going to be poem, and they added it on because they do have other esophageal myotomy codes, but they're by different approaches. So we had, for instance, the 32665 is an esophageal myotomy by thoracoscopy. And then we have 43279, which is a laparoscopic esophageal myotomy. And then 4333, which is an esophageal myotomy by open abdominal approach. So they have all these different approaches, but they did not have and endoscopic one. So now the poem has been added to cover it from an endoscopic approach, which is kind of nice. So they kind of full circled out everything there. Now the interventional cardiology, that I think is and it wasn't talked about so much, but that's where the CAPT codes got the change. And to me, that was a full stop for me moment, because I am involved in cardiology, and I had not, for some reason, I don't know why, I just didn't, maybe I wasn't paying attention to the other stuff. I didn't see that one coming like that. But take a look if you do cardiac caths. They have totally changed the cardiac caths for congenital cardiac anomalies. So they also added some new codes for cerebral embolic protection and endoscopic repair of aortic coarctation. But the congenital cardiac defects, that one is now changed from, it's changed now to split out by whether or not the patient has normal anatomic flow or not. So you're going to have to more look at not just the fact that they have a congenital anomaly, but what kind of a congenital anomaly that they have, and whether or not the flow is normal or not from that aspect. So they were showing some examples. So when I would suggest, if you do cardiac caths, that you go back and get the like CPT changes to take a look, or of course look at, you know, the societies for some different things, or just to the AMA. I'm sorry, I'm getting a question here. Would I repeat the poem codes? Of course I will repeat the poem codes. Let me find them again. There's my stuff for ice. Cardiothoracic, here we go. So the poem codes currently, we have 32665, which is for via thoracoscopy, 43279 for laparoscopic, and 43330 for abdominal. And then the new one is 43497 for endoscopic. So back to interventional cardiology, make sure you check that out. If you work in cardiology or PD cards, that's something that could definitely affect how you're reporting services this year. And as I was saying in the other sections, more category 3 codes are being added into this section too. Under the urology, we have some bioresorbable controlled released hormone implants. You're welcome, Kimberly. Repair of hypospadias. So those are the two new codes in category 1 section there. And hypospadias is when the urethra on a male doesn't go all the way through to the meatus of the penis like it should. With hypospadias, it opens underneath. With epispadias, it opens on top, but not all the way down to the meatus. So the urethra just doesn't go all the way through the penis. So they have repair codes both for hypospadias and epispadias. And so they added some new repair codes in the hypospadias section. They also have some category 3 codes for uterine transplants, since now, you know, for those of y'all that are in this area specialty, or have just kind of noticed in the news, that's becoming a little something we're seeing a little bit more of, is the uterine transplant. So now they have some category 3 codes in there for when it's performed, to kind of see, you know, how often, you know, this procedure is going to be doing. So is it efficacious? Are we having good results with it? That kind of thing. So something to check out if this, again, is under your specialty purview. And then they had a social determinants of health presentations. As I said, they had 3 different ones. They had one on how they related to the E&M visit. So they had a presenter from the AMA that went through different examples of cases of a patient that, is suffering, a teenager suffering from anxiety. So she's been absent from school for too many days. And so now she's, having trouble with school. So they're coming in to try to, help her out with her anxiety so that she can get more back into, the natural habit of school. They had one where it was a gentleman that was a diabetic that was not taking his medications correctly because he and his wife had issues. And so his wife had put him out. So he was kind of sleeping in the car kind of thing. So he wasn't eating regularly. And, he had home irregularity and instability there. And so it was just showing different tidbits of documentation points and things like that, which I thought was pretty cool. And then they had an ICD-10-CM presentation on the background of the SDOH codes and the spreading there. We did get some additions to them this year and why they're important to track. And then there was a gentleman that spoke on the interoperability. And I thought it was very neat. He was talking about different projects that are out there and how they're trying to track these things and what they're doing, with the information that they're getting. So it was pretty cool. So that was something that they were able to do with Symposium this year because it was virtual. They had a little bit more time to play around with. So they were able to add in, this extra section, which I thought was very interesting. It was pretty neat. Okay. So that's a whole lot of stuff. As I said, it was a lot of stuff that I went through very quickly here in less than an hour. Oh, I kept it to 45 minutes this time. That's pretty good for me. But it was 2.5 days, and there was an awful lot of changes that I could only kind of hit highlights through, because it just time doesn't allow for it. I mean, the shortest sessions at the symposium were half an hour, and sometimes those doctors were rapidly speaking to try to get everything fit in that they were doing. So one of the things that we are doing here at Compliant Healthcare Solutions is holding a coding updates workshop for 2022. That's going to be on December 4th. So it is from 9 to 4:30 Central Standard Time. It's going to be virtual and live. And so as long as you have an internet connection, you can attend from anywhere and ask questions and get some more specifics on each section. It has been pre-approved for 7 CEUs through the AAPC. So they can also be used for AHEMA CEUs too. And as I said, it's live and virtual. And I am charging the fee of $50 for this month to try to help people out and get everybody ready for next year. And this is the link for it. And I will put the link in the comments on LinkedIn if you want to go take a look. The link is to the registration form. So I just put it out in the comments for y'all. If you also look on the screen here, this is what it looks like. It just kind of goes through that the workshop is on the 4th with the information. And I've been getting a lot of questions of people with the registration form. So I just real quickly wanted to say, if the top up here for the please print and put your stuff in there, then have the attendee name, if it's the same information, no, you don't have to put it in twice. You can either put it in up here and then just put your name there. This was more made for kind of like roster billing if a company was going to send multiple people. So up here would have the practice information and things like that. And then they would just be able to list the people's names that were going to attend with and their email information there. So if you're attending solo and you're doing this on your own, you can just fill out the attendee registration information right here once. Also, I've had people ask me about sending financial information, and if you would rather not scan the form and send it back with financial information on it, you can just fill the attendee portion out right here and send it in to us, and we'll invoice you so that you're not having to worry about, faxing something or sending something somewhere and not sure about, who's seeing it. So we'll send you an invoice, and then you can just pay the invoice online, or you can fill out the registration form and mail it to the office with the check. So however you would like to do it, if you would like to attend. So that is all I wanted to show you on there. So I'm going to stop sharing my screen. So I hope anybody that wants to come, I will also post another thing on LinkedIn for it, because some people were saying they were having some issues before. I pushed it a couple of times, but technology is great when it works, but sometimes it doesn't exactly cooperate with me. So I apologize for anybody that's had trouble. So I hope this gave everybody a little bit of an idea of what we're looking at for next year. And that doesn't even count the final rule and the physician fee schedule issues with the conversion factor. The conversion factor was decreased by $1.30, by the way, for next year. So they're also playing around with some other things in the different areas. So you can't look at it as a straight $1.30 decrease, because depending on what area and what code you're talking about, the RUC did some revaluation and CMS did some revaluations of a lot of codes. And so some of the things you see even a deeper decrease than that, and some may actually end up with an increase because of how they're off shifting some of the things and changing up some of the RVU values. So I'm still kind of studying it, so I will be putting something out on that soon. Maybe a healthcare happenings on it. And I want everybody to know I'm really, really excited, because one of my colleagues who is a healthcare attorney has agreed to do a healthcare happenings with me in December. So let me look. I think it's the 9th of December is what he said he could do, which is a Thursday. So because of Thanksgiving and, I'm trying to work things around, and December 5th through the 8th, I will be exhibiting at the NAMUS conference in Clearwater, Florida. So if you're attending that conference, please come and visit me, say hi so we can chat. And so I kind of had to shift around when we're doing the next healthcare happenings, and, with his schedule. So watch for that posting, because we will have a healthcare attorney on, and, I'll be asking them things about, what different kinds of things he does and can help practices with. And y'all will be able to, ask questions of him and things like that, where if you're wondering about different things in your practice, and or like E&O insurance and things like, do I need it? And different kind of stuff. So I think that will be pretty cool. And I'm real excited that he can join me. So watch for that notice coming up. And if anybody's got any comments or questions, if you want to go ahead and put them in for me now, I'll give a few minutes as I look through and watch for something. If not, just watch for my next notice for Mike when we do our session. And everybody have a happy Thanksgiving. I know this is Thanksgiving week, so I hope everybody's going to be able to have an enjoyable holiday and be able to spend time with their families and relaxing and doing things like that, because everybody needs it. And I hope everybody's taking care of themselves. So I see, oh, Edwina says, thank you. You're quite welcome. Kim, you're quite welcome again. And oh, I'm glad if you can make it, that would be great. And I'm not seeing anything else come in. So I think I will go ahead and end this session of Healthcare Happenings on the 2022. You're quite welcome on the 2022 coding updates. Lady, you are quite welcome too. And I hope to see everybody soon, and happy Thanksgiving.